Good afternoon, everyone, and thank you for joining us for the webinar today, SEER-MHOS Data Resource Webinar, highlighting newly available Medicare Part D claims data. My name is Stephanie, and I will be your WebEx host. Before moving into today's webinar, I'd like to go over a few logistics. All lines are in listen-only mode, and if you need to view live closed captioning, you can select this by using the Media Viewer panel on the right-hand side of your screen. Should you have any questions at all during the webinar, you can submit them at any time during the presentation. Just type it into the Q&A or chat panel and select Host from the drop-down menu. We will ask those questions on your behalf at the end of the webinar. As a reminder, this webinar is being recorded and will be posted online in the near future. And now I'd like to pass it over to Dr. Roxanne Jensen.
All right. Hi, everyone. Welcome. Thank you for joining us today. My name is Roxanne Jensen. I am a program director in the Outcomes Research Branch at the National Cancer Institute, and I am the scientific lead for the SEER-MHOS data resource. I am joined today by Dr. Amy Davidoff. She's a senior research scientist at the Yale School of Public Health and affiliated with the Yale Cancer Outcomes Public Policy and Effectiveness Research Center. On this webinar today, we will provide some background on SEER, Medicare, and the Medicare Health Outcomes Survey, discuss the new addition of Medicare Part D claims data to the resource. Then Dr. Amy Davidoff will present her project examining pain interference and pain management using the SEER-MHOS data resource with Part D claims data. And then I will discuss the application process with a focus on projects proposing the use of Part D claims. And then we will take your questions. So the Surveillance, Epidemiology, and End Results SEER program provides information on cancer statistics in an effort to reduce the cancer burden among the U.S. population. The SEER Cancer Registry data file is a comprehensive population-based source of cancer data in the U.S. The cancer registries represented in the SEER cover roughly 34% of the U.S. population. SEER contains demographic information and cancer information such as primary tumor sites and morphology, cancer stage of diagnosis, and initial course of treatment, radiation, and surgery. It's important to note that the SEER data in SEER-MHOS does have a vital status indicator that is updated with each new data linkage. This enables researchers to perform survival analyses with the SEER-MHOS data resource. The second linked data source are Medicare beneficiaries, specifically those enrolled in Medicare Advantage. Medicare provides insurance coverage for about 50 million beneficiaries. These enrollees are typically 65 and older, younger people with disabilities, or people with end-stage renal disease. Medicare Advantage is offered by private insurance companies approved by Medicare. Medicare Advantage consists of managed care plans, which pay per enrollee versus fee-for-service. This distinction is important because this means there are no Medicare claims available for this data resource. Over 1/3 of Medicare beneficiaries are currently enrolled in Medicare Advantage plans. The Medicare Health Outcomes Survey is a survey of Medicare beneficiaries enrolled in Medicare Advantage. All Medicare Advantage plans with over 500 enrollees must participate, and a random sample is drawn from each plan. Surveys are administered by mail or telephone, and follow-up occurs 2 years later with the same person. So the survey captures a wide range of health outcomes, such as health-related quality of life. This can include physical health, mental health, pain interference, depression, limitations to activities of daily living, ADLs. There are questions that are used to create HEDIS effectiveness of care measures, quality indicators. This includes risk fall management, urinary incontinence, and there are additional variables of interest, such as self-reported smoking history, self-reported comorbidities, and BMI. The response rate is 63% for the baseline and 89% for the follow-up survey. So the SEER-MHOS data resource represents the overlay of these two data resources. So where someone is diagnosed with cancer at any point since 1973 within a SEER registry catchment area is then at some point later enrolled in Medicare Advantage plan, and then was randomly selected to be part of the MHOS sample cohort, consisting of 2 surveys 2 years apart. And also please note that the SEER-MHOS data resource also includes non-cancer cases to provide a comparison group to the cancer cases. This map displays those cancer registries that are included in SEER-MHOS. SEER-MHOS does not include Alaska Native and Arizona American Indian registries. And this slide represents numbers of the most prevalent cancer types available in the SEER-MHOS data resource, and when the surveys are occurring relative to the cancer diagnosis. As you can see, there are large numbers of prostate, breast, colorectal, lung, and bronchial, and this data is representing 1998 to 2017. About 6% of the patients for each cancer completed a survey before and after diagnosis. That means they were enrolled in Medicare Advantage, completed a survey, the SEER-MHOS survey, then within the 2-year period before they completed another survey, were diagnosed with cancer. This is a very unique cancer population to study and one of the true highlights of this data resource. And you'll notice, while all of these cancer cases, you see they have surveys after diagnosis, the rate for lung cancer is 30% versus between 66 and 77%. And that's due to a lower life expectancy for lung cancer. So people don't have as long to fill out a survey after a lung cancer diagnosis. These numbers highlight some of the strengths of this resource. There's large sample size from many cancer sites. It's one of the largest data resources on patient-reported outcomes among cancer patients in the U.S. And there's an ability to look at change over a 2-year period. And finally, you can compare it to individuals. You can compare individuals with and without cancer. All right. So for now I'll move on to talking about Part D. But for more information and more in-depth information about the data resource, including a deeper dive into the questionnaire SEER-MHOS data, I would encourage you to visit our website and review our introductory webinar for a little more information. Okay. So a little background on Part D, Medicare Part D. This is a voluntary prescription drug benefit that started in 2006. Part D plans may be offered as standalone or linked to Medicare Advantage plans. Most Medicare Advantage plans offer a linked Part D plan, and so as a result, many of those enrolled in Medicare Advantage have a Part D plan. And most relevant to cancer patients, Part D plans cover most oral chemotherapy and other systemic therapies, supportive care medications, and medications for the management of acute and chronic conditions. Part D plans do include cost sharing, such as deductibles and copayments, and low-income beneficiaries may apply for cost-sharing reductions known as low-income subsidy. Here's a list of some of the selected Part D data elements that are available. Up at the top, you see the patient or beneficiary ID, which is a common identifier for linking claims to respondents in SEER-MHOS, to the date of prescription fill. And in light blue, there's a series of variables to identify the specific medication, how it's administered, and quantity. There is currently no linkage to Part D plan formularies or plan characteristic files for SEER-MHOS. So the info that's highlighted in green at the bottom, tier, maximum step number, quality limit, prior authorization required, the use of this information would be limited as that it's used often in conjunction with that information. All right, so what does Medicare Part D measure? Medicare Part D claims identify what prescribed medications are filled, and this can include a daily dose, duration of single fills, duration over time for medication with chronic use, medication switching, dose changes, discontinuation, and medication adherence. Claims-based measures, though, it's important to note that they reflect the medication availability, but not if they were actually ingested. So to sum up, this is a graphic detailing the data availability for SEER-MHOS survey, the cancer diagnosis or SEER data, and the Part D claims. And you can see all of them start and stop at different dates. And this is something to really keep in mind when you're setting up your research question using this rated source. SEER or cancer information goes back to 1973 up to 2015. MHOS is updated cohorts every linkage. We have 1998 to 2017, and Part D claims we have from 2007 to 2016. Each of these will be updated in future linkages. However, this is what we have available to date. And so finally, I'd like to present a table that reflects SEER-MHOS with Part D data. This is a very similar table to the one I showed you before. However, this is the numbers based on Part D data that's linked. And this data reflects 2007 to 2014. So there are a few additional cases that have been added in a most recent linkage. But you can see here, again, you have close to 50% with at least one or to have two surveys after diagnosis. And you have a good number of people, about 12%, that have a survey pre and post-diagnosis. This gives you a lot of options when you're trying to think of research questions using Part D data in this population. And now I'll turn it over to Dr. Amy Davidoff.
Okay, well, thank you very much, Roxanne, for the great background and the introduction. I'm going to be talking about one of several projects that a team of us at Yale did as part of a demonstration of the feasibility of working with the linked data set to address some important questions. The work that I'm going to present today has been accepted for publication in support of curing cancer, and you can see the citation there and a link, including my wonderful colleagues who helped me on this project. So pain is highly prevalent among older adults. About 29% report persistent pain. So there's been concern about adequacy of pain management. Are patients who report pain receiving treatment? Are those who receive pain treatment still reporting pain? In other words, is pain management adequate? And then, is adequacy of pain management similar for older adults with and without cancer? There is a perception that patients with cancer may be under or overtreated relative to older adults without cancer. There is a large literature that describes patterns of opioid use in particular for cancer compared to non-cancer. But there are no large population-based studies that actually adjust for reported pain severity. And since that may differ for adults with and without cancer, it's important to adjust for that when assessing pain management. So the study aim is to examine patterns of medication therapy for pain management in older adults with and without cancer. Our study design is cross-sectional. We considered trying to look at only those observations that had 2 Emhoff surveys so we could see whether there was a change in pain management and pain report over time. But we were concerned about sample size, and so we decided to do a cross-sectional study. The outcomes of interest were medication for pain management and opioids use, detail on opioid use, and then other types of pain medications. The key independent variables of interest were pain interference and cancer status, whether you were someone who was a cancer survivor or not. We generated descriptive statistics and ultimately ran multivariable logistic regression models. The dependent variables were either any pain medication or any opioid receipt. And these are all measured within the 30 days prior to the Emhoff survey. And then we pooled our cancer and non-cancer cohorts, and we interacted pain severity and cancer status in order to test whether there were differences in medication management for cancer versus non-cancer across different levels of pain severity. Our covariates in the analysis were the usual demographic characteristics, health conditions as reported in a chronic condition checklist on the Emhoff. We included an indicator for whether the individual was enrolled in an HMO versus a PPO, and whether they had the Part D low-income subsidy or extra help. So just a little bit about our methods, and these would be relevant for you if you're considering a study. You need to think about sort of what the relationship is temporally between the cancer diagnosis that's reported in SEER and the Emhoff survey. Do you want to have an Emhoff survey that precedes the cancer, that is after the cancer diagnosis, and how far you are going to allow those a temporal gap. And then you also need to think about how to refine this when there might be more than one cancer primary or more than one Emhoff state. Because we wanted to compare pain report and medication therapy for Medicare beneficiaries with and without cancer, we wanted to make sure that the Emhoff pain report is fairly soon after, or as soon as possible after the cancer diagnosis date, when the patient still may be experiencing symptoms from the cancer or from the therapy. Now, obviously, some patients have very limited time frames when they're experiencing this, and others may have much longer time periods when they're experiencing pain after cancer. So we decided to use a 5-year window. So for our sample selection, we required that they have only one cancer primary reported in the SEER registry. Pulled those for January 2003 through December 2012. They had to have completed at least one Emhoff survey between 2008 and 2012. And the first Emhoff date had to be within 5 years after the cancer diagnosis. And you can see our little schematic there, the Emhoff date between 2008 and 2012, and the cancer diagnosis less than 5 years prior to that Emhoff survey. So other considerations is really the observation period that you want to use for the prescription drug use, because this will determine how long you have to require continuous Medicare Advantage and Part D enrollment. And not only that, you need to consider, if you're relatively new to using Part D claims, that if you have an observation period, you actually need to look at drug fills that might have occurred prior to that observation period, because oftentimes a fill might be for a long period of time and might actually spill over into your observation period. So we selected the time period of 12 months before and 12 months after. Now, we actually didn't use that full time span for this particular project that I'm going to describe to you, but we were doing other projects and wanted to make sure that we were sort of drawing in certain time periods that would be relevant for all of the studies that we undertook. So we required that they have MA and Part D enrollment 12 months before and 12 months after the Emhoff date that we had selected. So further sample selection, we started out with 48,949 in the total Emhoff cancer sample. After these are patients who have cancer that's linked to Emhoff, known date of cancer diagnosis, etc. And then when we require that they be age over 65, because we wanted to focus on older adults, and an invasive tumor, we come down to 32,000. When we put our time frame in there of when they're surveyed in relation to the cancer diagnosis, it drops down to about 12,000, etc. And you can see on the right-hand side of the slide that we have a similar sample selection process for a sample of individuals who did not have a SEER cancer but had responded to the MHOS and lived in the SEER region. So we ended up with a total of 9,100 with cancer and about 6,500 without cancer to compare to, for a total analytic sample of 15,624. So the Emhoff survey itself has some options in terms of how we could measure pain, but the questions changed over time, and we needed to carefully select questions that covered the majority of our time frame. Between 2007 and 2012, there are questions about activity interference associated with pain in the past 4 weeks. In addition, there are several questions about chest pain, low back pain, etc., but we felt these were not sufficiently universal to incorporate. So we focused on the activity interference with pain in 4 weeks. Now, starting in 2013, there are new questions that focus on the last 7 days and are a little different in terms of the wording related to day-to-day activities or social engagements. And there's also a pain scale, which will be a very interesting addition as a resource for analysis. So things to look forward to. So the pain measurement for this study used the Emhoff question: during the past 4 weeks, how much did pain interfere with your normal work, including both work outside the home and housework? And there's a five-level response, and we lumped the top 2 and the bottom 2, so ended up with a severe, moderate, and mild or none. Okay. So in order to identify our pain therapy, we needed to identify the relevant medication classes, which we did by looking at the literature, looking at guidelines for pain management, and then we had several wonderful clinicians in our team who are palliative care experts, and they gave us feedback throughout. We identified, once we had the classes, we identified the relevant generic drugs within the class. And then we selected the relevant records within the Part D claims. Now, to select, once you know that the type of drug you're looking for, you can either use NDC codes or generic drug names to identify the actual claims. We decided to use the latter. We used the generic name field for the drugs. We used string search to identify combination drugs. And then our palliative care clinicians confirmed the relevance, particularly when we had combination drugs, relevance for pain management. So we selected claims that had drug supply 12 months before and after our Emhoff date, again, to be useful for other studies that we were doing. For this particular study, we focused on the 30 days prior to the Emhoff survey date. So the medication classes we included were opioids, both short and long-acting, non-opioid analgesics, NSAIDs, and local anesthetics, and adjuvant pain medication, anti-epileptics, and selected antidepressants that tend to be used more for pain than for depression. We do note that steroids are commonly used to manage pain, but they're also used to manage nausea and as part of chemotherapy regimens. And because we only had access to Part D information, we could not identify sort of other symptoms or chemotherapy regimens that might be ongoing where the steroid would be a component of that. And because we were unable to assign a therapeutic role to the steroids, we did not include them in the category of pain medications. Once we had pulled our claims, and particularly our claims for the 30 days prior to the Emhoff survey, we created measures for any use, the category of medications, for opioids, the specific agents used, the duration, the morphine equivalent daily dose, and the initiation of opioids after the Emhoff survey. We considered both sort of measures of untreated and undertreated pain, particularly patients who are reporting severe pain and not receiving opioids, or patients receiving moderate pain without any pain medications. The morphine equivalent daily dose that I mentioned is a way of creating equivalence across different types of opioids because they do differ in their strength. So they're all there are conversion factors that are used so that there's a common metric. So we identified all of the opioid prescriptions with supply on the Emhoff date or the closest date within that window. Going backwards, we calculated the daily dose for the oral tablets. We then converted the daily dose to this morphine equivalent daily dose using conversion factors that we pulled from the Centers for Disease Control and modified by the Centers for Medicare and Medicaid Services. When we had more than one opioid that was used simultaneously, which is very common, then the morphine equivalent daily dose was summed to calculate the overall dose equivalence. So some results from our study. This slide just shows an overall description of our medication use for management of pain by cancer history. And so you can see that we report for any medication use, opioids, non-opioid analgesic, and adjuvant pain medication, overall for cancer and for non-cancer. So overall, 21.5% received any pain management medications, with slightly higher, 22.5% of cancer population receiving any medication, and 20.1% for the non-cancer comparison group. The percent receiving medications was somewhat higher for the adults with the cancer than non-cancer for all of the different categories, although the differences were not particularly large. And remember, this is not adjusting for pain severity. The next slide shows similar results, but this time looking at differences by pain severity of pain interference. I apologize that we've got two bluish bars in there, but the first one is the first somewhat blue or green one is the estimates for those with severe pain. The middle group is for those with moderate, and then the final group is for mild or no pain severity. And you can see there's a monotonic association between the level of severity and the percentage of patients who are receiving medication. And all of these differences across the severity category are significant. This just gives you a list of the specific opioids that were used, with the highest being hydrocodone and oxycodone, names that are commonly heard in the news. So this just gives you a sense. We didn't find that there were differences between the cancer and non-cancer samples in terms of the types of opioids that were being used. When we look in detail at the opioids, first looking at the duration of opioid use prior to the Emhoff date, we see a real mix with a fairly substantial group having fairly short-term exposure to opioids, and then almost 40% overall having had opioids for at least 30 days. No difference between the cancer and non-cancer groups. For the MEDD, we have fairly similar medians across groups, but the mean for individuals with cancer was 58.3 milligrams compared to those without cancer, 50.7, and that is a significant difference. We also looked briefly at whether there was a high or very high MEDD. above 90 milligrams. And we found that overall almost 15% had that very high dose, but that there were no differences between individuals with and without cancer. The results of our logistic regression analysis are presented here as adjusted relative risks. You can see that the biggest factor is pain severity with significant effects for cancer. I can give you the overall interpretation of these interaction terms in 2 slides. But other factors that were significant, we did control for proximal death, so whether the patient died within 6 months after taking the Emhoff, and that was a significant indicator or predictor of increased risk of having any pain medication. Other factors, increasing age and Asian or other race ethnicity, were associated with lower rates of pain medication. Part D LIS was associated with higher risk. When we focus in on opioids, the results are a bit more extreme in terms of, say, the risk associated with severe pain, moderate with cancer, proximal death, and then a number of factors that were not significant in looking at any pain are in fact significant when we're looking just at opioids. And you can see factors such as Black race, Hispanic ethnicity, marital status, education, poverty come up now as significant, whereas they did not before for the any pain management. So here's a slide showing sort of what happens when you pull together the separate results for cancer history and pain severity using predictive margins. Predictive margins provide the predicted probability when you're sort of turning on and off various dummy variables. And so you can see here that for cancer patients with severe pain, predicted 38.7% received any pain medication, compared with adults without cancer, 37.1%. So that's you can see that there's a higher predicted probabilities across all of the pain severity groups, although it's only significant for the severe and mild non-groups. You can see that this pattern of results holds also for opioids, where the individuals with cancer have higher probability of receiving an opioid compared to those without cancer across all 3 severity categories. And these are significant, again, for the severe and the mild non-categories. So just to discuss briefly, this analysis looked at a snapshot in time, a 30-day period, suggesting relatively low use of medication therapy for pain, particularly opioids. Although we would have liked to have a sort of newly diagnosed cancer patient population, the 5-year window gave us somewhat more of a prevalent cancer population, and I think that the medication use is probably consistent with that more prevalent cancer population. Appropriately, we observe that medication use is higher with higher reported pain severity. There seems to be evidence of under or untreated pain. Only 30% of those reporting severe pain received an opioid. And we would note that that actually taking the Emhoff survey may have somewhat of a Heisenberg effect, in that it may sort of alert patients to be thinking about their pain. They may end up reporting pain to their physician, and so there may be the addition of pain medications after the actual Emhoff survey. But that is not within our observation period, but it is part of some of the other studies we're looking at. So overall, the receipt of pain medication was greater in older adults with cancer, even after adjustment for different characteristics, including severity of pain, interference. It may be that oncologists are better tuned to pain management issues or have less constraints on prescribing opioids. We note that race, ethnicity, and socioeconomic differences were present, particularly with respect to opioid use. We saw lower opioid use in race and ethnic minorities, but higher opioid use with higher poverty rates and with the Part D low-income subsidy. So there's clearly some issues there related to access to care that are likely affecting access to pain medication management. So with that, I will thank you and turn things over to Susan, I believe.
Okay, well, before we get to Susan, I'm going to take us through very quickly the application process for SEER-MHOS with an emphasis on Part D requests. So these are the pieces that an investigator needs to apply for SEER-MHOS project. A cover letter, application form, IRB approval as required by your institution, a signed data use agreement, and a request for any restricted variables if necessary. The process, as you can see, there's a lot of steps in this process. For investigators, focus on the purple boxes. You're developing your proposal, it is then reviewed, there may be some revision, it's reviewed by CRPI. Then once we have approvals, payment needs to be received, revised as necessary. Green is a milestone of approval. And then we move forward into finally the final green box at the bottom is the data is released to the investigator with a 5-year DUA. And after 5 years, the DUA can be renewed on a yearly basis as necessary. So you can see our website says this takes between 3 and 4 months to go through to getting the data released. We encourage you to talk with us when you're starting the proposal process, and as you're thinking through your ideas. Some common application considerations. Accurate cohort selection for your research question is really important. You should define clearly why you are selecting the cancer sites or types that you are. You need to give good consideration to the timing of the cancer diagnosis in relationship to the survey. And then also, finally, clearly define why you need a non-cancer comparison group if you are requesting one as part of your research questions. I think keep careful considerations about changes in survey content over time. The MHOS survey does change. There's 3 different versions from 1998 to the present, and so you need to be mindful that the content you are considering is available. And always think about sample size and power because things can get small very fast based on the available data. And I think most relevant for this group is that you need to be thoughtful about how to justify the need for Part D data. Just saying that you have it and want to use it is not going to be enough. We'd like to know a little bit more about how it's being used and integrated in the research question. And so as Part D justification, think about how it's represented in your aims, methods, variables, analytic plan. I think thinking about sample size issues specific to the years and available Part D data is important. Documenting in your application availability and the feasibility of getting the claims that you want. And then also, finally, as part of your research team, having someone with demonstrated expertise on Part D data is very helpful. Okay, and before we wrap up for questions, I want to direct you to 2 helpful resources. The first link is to DUAs that are public using the SEER-MHOS data. These are applications that investigators have submitted and indicated that they are happy being public, and so these are lists of research aims and current ongoing projects. The second bullet is a list of SEER-MHOS publications. So this can direct you to things that are out in the published literature and maybe also help you think about ways investigators are using this data resource. All right, so without further ado, I think I will hand this over to Susan Buckelmeyer to run the question and answer session.
Thank you so much, Roxanne, and thank you, Amy. I will now be starting the question and answers. As a reminder, you can type in your questions into the chat box that was mentioned at the beginning of this webinar, and we will get to as many as possible that we can. So I'm going to start with this first. It's a two-part question. I'm going to direct it to Roxanne. The first part of the question is, what types of claims are available in Medicare?
What types of claims are available in Medicare? So for this SEER-MHOS data resource, the only claims that we have available are Part D. That's it. And so please, we do not have utilization data. We do not have A or B. Thanks, Susan.
Okay, thank you. It looks like another question is coming in, asking if there are any in-depth trainings available on how to use the Part D claims. I'm going to direct this to Roxanne.
Okay, thanks, Susan. So there are two resources I would direct investigators to. NCI periodically offers SEER-Medicare training for researchers interested in learning more about these data. There was one recently this fall. You can go to the SEER-Medicare website, and there are the slides and videos from the most recent training. And there is a section on Part D data. And so while in general it is geared towards fee-for-service, I think there's a lot to be taken about the Part D and the SEER variables too, for anybody interested in working with the SEER-MHOS data set. ResDac, which is an external site, also has a variety of workshops and online videos that describe Part D and the claims. So I think while the Part D files on the ResDac site, they're slightly different than the ones we're presenting here. It's not than those linked to SEER-Medicare. I think the underlying concepts and approaches to using this data are the same and would help people, investigators, thinking through their research ideas and using this data resource.
Thank you, Roxanne. Up next, a question came in. I'm going to direct towards Amy. So we'll let her come off mute. And the question is, what type of breaks in coverage would show up in Medicare Part D claims? For example, if a patient switches plans for a period.
Well, it might actually not come up as a Part D claim, but it would come up as an indicator in the enrollment file. So there's an enrollment file that indicates on a monthly basis whether the individual is enrolled in Part D and also enrolled in MA. And if you see months where that doesn't occur, then that is a break in coverage. Typically, we assume that if there's a 1-month delay break in coverage, that there's some administrative snafu, and we tend to ignore those. But if there's any period longer than that, we might exclude the individual home sample selection process.
Thank you, Amy. We got another question that came in that I'm going to direct towards Roxanne. It asks that they understand that SEER-MHOS has publicly available data through 2017. But what are the different time periods for Part D and SEER?
Thanks, Susan. So SEER-MHOS data is available from 1998 to 2017. However, the Part D claims that we have associated with the MHOS data run from 2007 to 2016. So I think that's important to keep that in mind when you're considering your research questions and sample size. When we link again, we linked spring of 2019, so this year, and we link every 2 years. In our next linkage, we will update Part D, we'll update the MHOS survey and SEER data, enrollment data. So everything will be updated in our next linkage. But until then, these are the this is the data availability that we have.
Thank you, Roxanne. Our next question is, I'm going to direct towards you, Amy, and it is, what drug information is provided in Part D, and also what is not included in Part D? If you can go through that differentiation.
Sure. So within the Part D claim, there's information on the date that the prescription is filled, the date it's dispensed, the amount dispensed, the supply, the NDC code, the brand name, generic name, drug plan code, whether the individual has low-income subsidy, a prescriber code, fill number, dispensing status, and information on the cost of ingredients and the fee for filling the prescription, and then lots of information on what is the out-of-pocket requirement for the individual. So that's Part D claims more generally. The SEER Part D linkage has a little bit more limited information, in particular but the date of fill and dispensing, the amount, the day supply, the NDC code, the brand, and generic name are all part of the Part D linked data. What's not included is any information on the medication class, the pharmacy, the information, and what's not included also in the Part D linkage is information on the prescriber, which is in the CCW Part D files. So a little bit different in terms of what's in the linked Part D claims compared to the full CCW Part D claims, but a lot of really important information about the drugs that can be used to describe patterns of medication use.
Great, thank you. That was very helpful. I'm going to direct the next question to Roxanne. It's about sample size and feasibility. For a specific project, what is the best way to get sample size or feasibility estimates? Is this something that can be provided to investigators before they apply for a DUA?
Yeah, thanks, Suzanne. There are a couple ways you can go about this. One great starting point is to get some SEER-MHOS sample estimates that can be generated through the SEER-STAT application. On our webpage, there's more information about there's a specific SEER-MHOS flag, so you can understand by cancer type and by specific information you care most about, you can understand who's in our data set linked to SEER, what kind of information we have, especially if you're looking at rare cancers. This can be very helpful. It will not tell you whether we have Part D data on that person that's in the larger sample. But I think it's a good place to start to see if you are in the ballpark. I think another step that would be very important for investigators that want to use Part D data is to email our help email, which is SEER-MHOS@hcqis.org. We have a SEER-MHOS Medicare Part D linkage technical report. It summarizes some of the information we discussed today and the challenges, and also gives some preliminary data, such as the data table I put up there. That's another place to look to understand feasibility and sample size of your study. And then also, I think, please reach out to us. This is a new linkage. It's just went online this year, and we're willing to work with people to a degree to just to assess feasibility before you go through the data DUA process, do the DUA process.
So we have a new question that just came in asking about after the DUA is approved,
do we have an idea of how much the Part D data will cost?
Yes. On our website, we have a cost calculator that will let you calculate the cost of your request. Then it includes the add-on of Part D. The cost of SEER-MHOS data varies by the number of cancer sites that you are selecting. So I would encourage you to go there to learn all the numbers that you may need to know.
Next question that came in, is there a way to get MHOS data linked to Part D without the SEER cancer cases?
So this question is asking if you can use this data with Part D but not focus on a cancer-related research question. And the answer is no. SEER-MHOS is a data resource that was designed to improve our understanding of cancer health outcomes for those enrolled in Medicare Advantage organizations. And our purpose is to focus on cancer, and while we are interested in cancer non-cancer comparisons, our DUAs that are submitted that do not focus on cancer populations will not be approved.
Thank you, Roxanne. We have time for a few more questions, so I'm going to direct this next one to Amy. How can you determine periods of coverage within the Part D data?
You can determine periods of coverage using the enrollment files, which are sort of an auxiliary file that should be merged in. That would really be the best way to assess gaps in coverage. Is that what the question was, or did I misinterpret?
Nope, I think that was exactly it.
Okay.
I think we're going to pause to see if any more questions come in very briefly before we wrap up. Okay, I think we did see one come in about the, to repeat the URL for the technical report request. Can we post that in the chat? So it's been posted in the chat, but I will repeat it very quickly. It's SEER-MHOS@hqis.org. But that should be posted in the chat as well for you to capture. A final question before we're done, I'm going to direct to Roxanne, and that's, are there any related FOAs or advice about where to seek funding for SEER-MHOS Part D projects?
Great question, Susan. So there are no specific FOAs in particular, but I do, investigators have reached out and written grant applications, such as R03s and R21s using this data set. I think, the thing though is we're always very happy to talk with investigators, both to talk about what their research questions are and refine their projects before they submit to the DOA. And I think anybody who's interested in this data set, these questions, we just encourage you to reach out to us to check about feasibility and what you are trying to do. We're here for you guys.
Perfect. Well, thank you everyone for joining today, and thank you for the great questions. As a reminder, this webinar has been recorded and it will be posted online in the next couple of weeks. So if you'd like to continue the conversation online or offline, you can do so. Thank you again, everyone, and have a wonderful day.